So there was one poster that did a cost analysis based on claims data, looking at, in particular, type 1 SMA patients. This included a separate analysis for patients who had not been receiving nusinersen versus patients who had been receiving nusinersen. The cost of nusinersen as well as the administration costs were excluded from the patients who were receiving nusinersen. And what was seen was that there was a lower cost and healthcare utilization in the patients that had been receiving nusinersen. Both numbers were significantly high, and this analysis did acknowledge that the cost and the burden of the disease is still quite high in both groups, but nonetheless it's less in the patients who have been treated with nusinersen. This also suggests that the burden is still quite high in patients treated with nusinersen, but that other measures can be taken, such as earlier diagnosis, earlier treatment, and potentially looking at other therapies that may have added benefit to these patients.
So cost remains a very important consideration, practically speaking, when we're talking about therapies that are available for spinal muscular atrophy, including both nusinersen and onasemnogene apavarvik. The analysis by the Avexis group presented at this meeting showed that when you take a metric such as an undiscounted quality adjusted life year index, the overall cost balances out by 5 years. Basically, it shows that the cost of treatment can be balanced out by the positive outcomes that prevent hospitalizations and thereby incur more cost. The availability or accessibility for treatments from a payment perspective has been an issue. In the managed access program, the gene replacement therapy was available on an individual institutional review board basis, where the medicine was given to children outside of the clinical trial who would have been ineligible for the clinical trial. But post-approval, I think what needs to go into cost considerations is sort of showing potential benefits along with risks and long-term outcome that need to be discussed with payers in detail, so that the adjusted sort of cost is shown in the long term. So cost consideration in the short term may seem pretty high, but the long-term adjustment seems to be balanced and of benefit.
So as we know, we have two gene-modifying therapies for spinal muscular atrophy, and both of them are high-cost drugs. And the centers that are providing these treatments are working vigorously with the administrations to come up with a protocol or strategies to how are we going to approach these high-cost drugs in getting these patients treated, because the cost of the medication should not keep us from treating these patients with spinal muscular atrophy. It's important for the institutions to realize that and have a multidisciplinary approach involving the financial group and the hospital administration to think about what are the strategies that we could use, to talk to our payers, how can we streamline the process of getting prior approvals for these treatments in the timely fashion. As we know, earlier treatment, better the outcome. As far as patients who are uninsured or underinsured, it will be helpful if we have some support groups or programs from the companies that is working on these medications. And there are already programs in place that we are currently using. We are fortunate to have those companies giving us those programs and support for the patients that we are using, but I think that can be improved.